The human respiratory system operates under one unforgiving mandate: continuously deliver oxygen to the body's tissues and extract carbon dioxide. When this continuous cycle breaks down at any point, cells lose their primary energy source, and systemic organ dysfunction quickly follows. To understand where these breakdowns occur, we divide the anatomy into two functional zones. The first is the transport zone, primarily the bronchi, which acts exclusively as a conduit to conduct air deeper into the body. As we see in this diagram of the functional zones, the air pathway terminates in the exchange zone. Here, inside the alveoli, the actual physical transfer of gases between the inhaled air and the bloodstream takes place. This internal network, the lung tissue or the contents, cannot move air on its own. It relies entirely on the container, the thoracic cage and the diaphragm, to create the mechanical pressure changes that draw air in and push it out. A structural collapse of the lung tissue or a mechanical failure of the diaphragm's pumping action both lead to the exact same endpoint. Gas exchange stops, setting off a cascade toward complete respiratory failure. Normal respiration depends on three perfectly matched physiological variables: ventilation, perfusion, and diffusion. Ventilation, or VA, is the raw volume of fresh air that successfully navigates the transport zone and reaches the alveoli. Perfusion, represented by Q, is the continuous flow of blood passing through the pulmonary capillaries, wrapping around those alveoli. For optimal gas exchange, these two variables must align. The volume of air arriving must match the volume of blood passing by, creating a state where ventilation equals perfusion. Because clinicians cannot visually inspect this microscopic balance at the bedside, they rely on arterial blood gases, or ABGs, to quantify how effectively the triad is functioning. This table outlines the precise mathematical targets we look for in a healthy ABG. The partial pressure of oxygen, or PaO2, should sit between 80 and 100 millimeters of mercury. Carbon dioxide, or PaCO2, should stay between 35 and 45. The blood pH tightly regulates between 7.38 and 7.42, and bicarbonate stays between 22 and 26 millimoles per liter. These metrics help us draw a strict clinical distinction. A low PaO2 on an ABG indicates hypoxemia, which is strictly a deficit of oxygen in the blood. This is different from hypoxia, which describes a state where the actual tissues and organs are starved of oxygen. Looking at this chart, we categorize tissue hypoxia into four distinct triggers: hypoxemic, where the blood lacks oxygen; circulatory, where blood flow is too slow; anemic, where oxygen carrying capacity drops; and histotoxic, where the cells themselves lose the ability to use the oxygen provided. Ultimately, if the lungs fail to maintain the balance of ventilation, perfusion, and diffusion, the direct result is hypoxemia or hypercapnia. This is the physiological definition of respiratory failure, and left unchecked, it starves the organs entirely. Hypoxemia results directly from specific structural or mechanical alterations occurring at the alveolar level. This diagram illustrates three mechanisms driving down oxygen. First, in alveolar hypoventilation, air entering the lung drops, often from CNS depression or a weakened diaphragm. Next, diffusion impairment thickens the alveolar membrane, creating a physical barrier oxygen struggles to cross. The third mechanism, VQ mismatch, occurs when the balance between air and blood is disrupted. It is the single most common cause of hypoxemia in clinical practice. We use this comparison table to differentiate these mechanisms by looking at PaCO2. In diffusion impairment, PaCO2 remains normal because carbon dioxide escapes easily through thickened membranes. In hypoventilation, however, PaCO2 is always elevated because lungs aren't moving enough volume. Analyzing the carbon dioxide level gives clinicians a precise tool to reverse engineer exactly which of these three mechanisms is driving the patient's oxygen deficit. VQ mismatch is a broad category. To treat it effectively, we have to split it into two extreme clinical patterns, based on which side of the equation is failing. This visual summary compares a healthy alveolus to two extremes, the shunt effect and the dead space effect. In a shunt, ventilation is blocked, but perfusion continues. Deoxygenated blood bypasses the lungs' exchange system entirely without picking up oxygen. The classic examples of a shunt are fluid-filled alveoli in severe pneumonia, or a total alveolar collapse known as atelectasis. The dead space effect is the exact opposite. Air reaches the alveolus perfectly, but a vascular blockage prevents the blood from arriving. The ventilation happens, but without blood to receive the oxygen, the effort is entirely wasted. This wasted ventilation is the hallmark of a pulmonary embolism, where a clot physically blocks the pulmonary artery. Look at the management strategies in the response box at the bottom. The clinical difference between these two states dictates how we use oxygen therapy. A patient with a severe shunt shows a notoriously limited response to supplemental oxygen. Pumping more oxygen into the airway does nothing if the gas cannot physically enter the fluid-filled alveoli. Reversing hypoxemia here requires fixing the underlying mechanical blockage, rather than just increasing the oxygen concentration. When we move from microscopic alveolar mechanics to the bedside, these gas exchange failures produce immediate, visible distress in the patient. Hypoxemia physically manifests through dyspnea, a rapid breathing rate called tachypnea, and cyanosis, a distinct blue tint visible in the nail beds and lips as tissue oxygen saturation drops. Conversely, carbon dioxide retention, or hypercapnia, presents with neurological signs. As CO2 accumulates, it triggers headaches, deep confusion, and asterixis, a characteristic flapping tremor of the hands. To stabilize a patient showing these signs, clinicians follow this emergency management approach, the ABCs. We start by securing the airway, ensuring a clear path for gas. Then we assess breathing by measuring respiratory rate and calculating oxygen saturation with a pulse oximeter. Next is circulation, where we check heart rate, blood pressure, and look for systemic signs of shock to confirm the blood is actually moving through the system to deliver the oxygen. Securing these ABCs and providing supportive oxygen buys the patient critical time. But true resolution only happens when you identify and aggressively treat the specific underlying cause, whether that requires antimicrobials to clear pneumonia or anticoagulants to dissolve an embolism. Not all respiratory failures hit suddenly. While acute cases leave the body no time to adapt, chronic respiratory failure evolves over months or years, forcing the body to compensate for the permanent loss of lung function. In diseases like COPD, the primary adaptation is renal compensation. When the lungs permanently lose their ability to clear carbon dioxide, the blood becomes acidic. In response, the kidneys step in and begin retaining bicarbonate. This steady accumulation of alkaline bicarbonate slowly pulls the blood pH back up toward a survivable baseline, keeping the patient alive despite severely compromised lungs. Pulling back, we can follow the complete physiological pathway on this summary map. It starts on the left with normal ventilation, perfusion, and diffusion. A failure in any of these creates blood abnormalities, driving down oxygen and raising carbon dioxide, directly yielding organ dysfunction. By tracking this specific sequence, clinicians can trace massive systemic organ failure back to a single microscopic defect in the alveoli. This provides the exact mathematical insight needed to decode the blood gases and select the precise intervention that restores gas exchange.